Well, hello and welcome to another edition of Health Solutions with Shawn and Jana Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, and I am streaming live from Coeur d'Alene, Idaho. Love me, Coeur d'Alene, and I'm loving the weather. It looks like our weather is turning around. It never is good for Memorial Day, but today it's turning out good. Post-Memorial Day, of course. So today I'm super excited to have Dr. Jared Wallen on our show today. He is a urologist, and we're going to be discussing erectile dysfunction. I'm just going to tell you up front, we're going to get into the anatomy and physiology of a male. So if you're not comfortable with that, you might not want to listen. But one thing is it is a true, it is a medical issue, and it can actually, and he's going to talk about that, it can actually be, can lead into a predictor of other medical issues. So without further ado, Dr. Wallen, welcome back to our show.
Hi, Shawn. Thanks so much for having me.
Yeah. So tell us a little bit as we introduce you. Tell us a little bit about your background.
Yeah, so I went to medical school at Rush University on the west side of Chicago, and then spent 5 years in urologic surgery training at University of Southern Florida in Tampa, and then did some clinical research with Gerard Henry out of Louisiana, who's a men's health specialist. Also the now chairman at the University of Southern Florida, Raphael Carrion, is a internationally known men's health specialist, just like Dr. Henry. So, the combination of working with both of those guys and just being able to work with all the other specialists throughout the world, and even within our country locally through the National Society of Sexual Medicine has been great. And obviously it's like you said, it's a little bit of a touchy subject, but we try to keep it classy as much as possible. But again, it is a very sensitive topic in the fact that, actually, if you have erectile dysfunction, it can be a 3 to 5 year check engine light for possible heart issues, whether that's coronary artery disease leading to a possible heart attack, whether that's, neural artery disease leading to a possible stroke type stuff. And so that can be one of the first warning signs that we ever know before we ever experience these things clinically.
So I know in a previous podcast before, you discussed why that is. Can you discuss why that is? Why would it affect the male anatomy before it would affect the heart or before it would affect the brain?
Yeah, absolutely. So this is a little cross-section of a penis. Basically, if we slice it in half, as much as gruesome as that is, and you can see the little artery that's running down the middle of the corpora on each side. And that corpora is basically the blood-filled chamber. If you think about the penis basically as an inflatable rod, it's basically a blood-filled chamber that fills with blood and essentially creates stiffness for an erection. And so that artery, the cavernosal artery, is actually 2 millimeters in diameter on average, which actually the coronary vessels leading to your heart are actually 4 millimeters on average. And so they're basically double the size as the arteries leading to the penis. And so typically you have to have about 60% blockage or so, or 70% blockage for it to clinically be significant as far as your heart goes, and potentially leading to heart attacks at that point. And for the same reasons, if you have a 50% blockage in the heart, it may not necessarily cause major issues yet, but that same 50% blockage may essentially 100% occlude the small 2 millimeter arteries leading to the penis. And so that's where it truly can be kind of a 3 to 5 year indicator. If you have erectile dysfunction, certainly something you should think about doing is getting your heart checked out and making sure, that all things are good upstairs. We always say that anything that's good for the heart is good for below the belt as well. But in this case, if there's something going on downstairs, that could be a potential warning sign for major heart issues potentially down the road.
So tell us what can cause erectile dysfunction. There's probably many causes of it, obviously. Let's go into the anatomy of it and what can cause it to begin with.
Well, yeah. So, there's kind of 4 main causes. Vascular dysfunction, like we just talked about, is the number one cause. That's about 40% or so. Then you can certainly have neurologic causes, whether that's diabetes attacking the nerves and the sugars in the bloodstream attacking the nerves, or whether that's a spinal cord injury or something of that nature, or even prostate cancer surgery, bladder cancer surgery, rectal surgery for rectal cancer, or colon cancer. these can all disrupt the nerve firing to the pelvis. And so that can certainly play a role from that standpoint. Beyond that, there's any number of other issues that can cause it, whether it's psychological. I mean, certainly sometimes if you remember, in order to get an erection, it's a parasympathetic response, which means that the vasodilation occurs to allow the blood to flow in and essentially kind of fill up that chamber and give you the rigidity or the stiffness. And so, for instance, from a psychological standpoint, say you're at odds with your partner and you've been having stressors and, whether it's financial problems or whatever other problems you have, if you just aren't getting along well and there's a lot of stress there, remember that stress response is typically kind of a sympathetic response and a clenching of the system and basically kind of vasoconstriction. And so that can kind of counteract the ability to get and or maintain a good erection. So, those are kind of the main kind of generalized categories that are out there. You certainly can have, other issues that go on that can cause it as well, though.
So that's great. Thank you for that explanation. I really appreciate it. So what about treatment? So, treatment obviously is going to be from more of an anatomy standpoint. If there's some psychology or sociology things psychology things involved, I don't think a urologist can really help with that necessarily. I mean, I suppose you do a lot of counseling on that, I'm sure.
Yeah. I mean, I think, certainly it's something where, that's where we work with other specialists, the sexual therapists or what have you, and refer folks to them and get them on board with that from that standpoint. But certainly, in the meantime, there's always, there's pelvic floor physical therapy, which can help kind of strengthen some of the muscles in the pelvis and kind of reinforce the vascular system. There's, obviously the oral pills, Viagra, Cialis, Levitra, what you name it. There's a number of them out there that probably you all have heard of. Beyond that, there's things like the little handy vacuum erection device that basically kind of engulfs the penis, and you kind of slide it on and essentially kind of pump it up. It pulls blood into the penis through a vacuum, essentially created in the tube, and that it causes engorgement. And that's kind of like an artificial way to kind of recreate what normal physiology does. Typically, that's used in combination with a little ring that goes at the base of the penis to kind of do what normally happens. Remember, so basically as the blood flows in and fills up these chambers, what happens is that the little veins that are in the penis actually are squished closed. And so that way, basically that blood can be trapped there. Normal physiologic response then is basically after orgasm, after ejaculation, the system kind of clamps back down, the sympathetic system kicks back in, and those veins are allowed to drain again. And that's how we get detumescence, or essentially kind of return to flaccidity. And so from that standpoint, there's those. Obviously, there are little injections that can be done to the penis. Basically, you take a tiny little insulin needle and just poke right through the skin into this corpora cavernosa chamber. And basically that delivers all the medications, all the signals needed for an erection, that basically bypasses the spinal cord, bypasses the brain. They mostly can overcome a lot of vascular issues, although not the most severe. And then beyond that, there are a lot of experimental stuff. Anything that's good for your heart, your brain, from a vascular standpoint, is also good for below the belt. So I would certainly say making sure you're getting plenty of rest. Sleep is so important. Making sure your hormones are normal and optimized and balanced. Again, just talking about sleep a little bit more. Basically, most folks are probably best served sleeping in about 68 degrees, and to help them get into deep sleep the most often, or especially that REM sleep. But also, we talked about previous conversations, if you, even just for 1 week, if you miss out on that 7 to 8 hour window of sleep and you're only getting about 4 to 5 hours for the week, your hormone levels actually drop to about 10 years your age. So, or 10 years older than your age. And so, from that standpoint, certainly making sure that's in check. Obviously, anything that's good for that. There are a slew of different supplements or what have you that can increase nitric oxide and or essentially are good for your vascular system, whether that's L-arginine or pentoxifylline. These are all different supplements and medications that are out there that can be helpful from that standpoint. Also I think there's a couple of different things that are still considered experimental from the sexual medicine societies. Those would be essentially stem cells, platelet-rich plasma or PRP, and then also what's called low-intensity shockwave lithotripsy or essentially shockwave therapy for erectile dysfunction, which basically is kind of taken from previous cardiac research in the initial phases where they delivered low-intensity ultrasound waves. It's not like you're actually getting electrical shocks or anything like that, but it's basically ultrasound waves that cause disruption and expansion and contraction of the cells, again, at a cellular level, to essentially cause, kind of some minor damages to where it essentially kind of causes the body or stimulates the body to regenerate. It's no different than if, say, you had a little mole on your forehead and you took a little razor to it, 4 or 5 times a day and kind of scrape the surface. Over time, likely what you would see is that your body's normal processes would essentially kind of regenerate and take care of that as you do that. Is essentially kind of exfoliation, right? So from that standpoint, the shockwave can be thought about similarly, where basically it's kind of delivering low intensity ultrasonic shockwaves to the penis in this case, and those big corporal arteries that we talked about. This whole pink stuff on the top is the entire corporal cavernosal chamber on each side. There's 2 of them that run the length of the penis, and basically they're big, smooth muscle, blood-filled tissues, right? And so it gets little shocks in there, or the little ultrasound waves in there, causing enough disruption to where it actually helps repair the the angiogenesis, or the vascular system, the arteries and the veins in the penis. And so that's one that's out there that certainly can be helpful. Important to note that with that one, ultimately you're going to want to make sure that you're using focused acoustic waved ultrasound and not radial wave ultrasound. There's a lot of different options out there. There's a Storz device that's probably the only one that's delivering focused acoustic wave ultrasound in the country right now that's FDA approved. And so from that standpoint, you certainly, if you're going to look into that type of therapy, you want to make sure you know what you're getting as far as what you're paying for. So focused acoustic wave ultrasound, shockwave lithotripsy for the penis is important, not radial wave. And then finally, again, to some extent, no matter what we do, in the most severe cases, we can never fix everything, unfortunately. But there's always the solution of the penile implant, which is basically an outpatient surgery. Usually takes roughly 30 to 45 minutes. And basically what it is it's a little 3-piece device that you see here, where you have essentially 2 little cylinders that go inside the penis, inside the blood-filled chambers where they normally would. It's basically a fluid hydraulic system. You got a little bulb, kind of like the old Reebok shoe. That's your pump. And then you have a little fluid-filled reservoir that's basically just it's filled with injectable saline. And basically what you do is you pump, and then these cylinders fill with blood, just like your corpora cavernosa would normally, and basically become rigid that way. And then ultimately you have stiffness or rigidity for sexual intercourse or what have you, any activities that you may participate in. So that's kind of the gamut. I know that's a lot of.
Yeah, it is. That was good. So let's, I love it, Dr. Wallen, because I know you're an expert on this subject, and I love it when I have guests like yourself, because it makes my job a lot easier. I don't really have to ask a lot of questions. You just go on. So I love it. Thank you. It was great discussion on the anatomy, physiology of it, and the treatment. So in a stepwise approach,
yep.
As a urologist, what would be your first go-to if somebody had erectile dysfunction?
Well, again, usually we typically try medicines first, right? Or lifestyle changes, right? So quitting smoking, quitting drinking, or at least cutting back on drinking if you can. Certainly smoking is very important, because that tobacco nicotine causes vasoconstriction pretty significantly, and also causes endothelial dysfunction as well. So from that standpoint, that's a huge problem. But again, a heart healthy diet, lots of fruits and vegetables, trying to have potentially more fish than red meat, and certainly making sure you're getting active every day, 30 to 40 minutes, 5 days a week. You should be doing some type of cardiovascular activity, even if that's just walking. That's even, a brisk walk can still, for instance, myself, I usually kind of low impact. One of my workouts throughout the week is about 4 miles walking, but I combine it with, 100 push-ups, and I also do kind of weights while I'm walking. And so basically in 4 miles in about an hour, I can burn 600 calories. And so that's pretty significant. And it's something that anybody can do. But so beyond that, otherwise we certainly talk about medications, but a lot of times remember that H&P, that history and physical for the patient is so important. If you've had major pelvic surgery, if you've had, spinal cord injury, if you've had other things go on, certainly that's something that you're going to want to discuss with your physician. And that may be, unfortunately, maybe one reason medications may not work for you. And actually even diabetes is known to be a problem where oral medications will fail in diabetics quite often. And so from that standpoint, we certainly go through the gamut and talk to them about all of the options, and at least kind of brush over the top of the 50,000 foot level of, here's all the options that are out there. We can start here, but there's certainly more down the road that we can try if, unfortunately, you fail with the medications or whatever other treatment we start with.
So let's talk about some lifestyle issues. You already mentioned it with smoking and drinking. So let's talk about alcohol and how it affects sexual dysfunction. Because I know some people, unfortunately, they feel like they can't even have intercourse if they don't drink. And so tell us what the effects of alcohol is on not just sexual dysfunctions, maybe erectile dysfunction, but what about orgasms and things like that? Talk about that.
Yeah, I think there's not a lot of clear-cut data out there, but I think certainly in moderation and not in acute nature, it certainly can be, it can lower your inhibitions and it can allow you to essentially kind of participate more freely. But certainly in a chronic situation, certainly that does have effects on the liver, right? And that's where a lot of your cholesterol metabolism occurs, and testosterone. Remember, testosterone is essentially an end product of cholesterol metabolism. Obviously, that happens in the testicle rather than in the liver itself. But certainly, if there's dysfunction with your cholesterol metabolism, it's also going to create dysfunction with your hormone production. So that can certainly affect it in that manner. Certainly, anytime, even talking about not even just necessarily the activities that we do as far as drinking and smoking and other drugs and such, but even just from a medical standpoint, from medications, commonly SSRIs or these antidepressants are actually used for ejaculatory problems, especially premature ejaculation. Although unfortunately, more and more data has kind of come out, and more and more patients have kind of come forward talking about the sexual dysfunction that can occur with those as well. And so, it's kind of a double-edged sword. Unfortunately, some of these medications, are only about 50% effective for, anxiety, depression. And then on top of that, you're getting, worsening of your medical problems, especially from a sexual standpoint. Unfortunately, if you're having anxiety, depression already, and then you start having, sexual dysfunction, that's not going to make your anxiety, depression any better. So, from that standpoint, that's certainly something to always discuss with your physician when you're getting prescribed these medications. Again, certainly all these possible options, whether it's, smoking cigarettes and the vasoconstriction, whether it's alcohol, chronic alcohol use, and the hit on the liver that happens, or even, for instance, cocaine. A lot of times that can precipitate that 4 to 6 hour or longer erection, which, basically what happens in that situation is called priapism, is the clinical term. But basically what happens is all the blood gets trapped in the penis, and it never gets new blood, and there's no oxygen and nutrients there after 4 to 6 hours. And until you relieve that, essentially you start to get cell death. And again, that can certainly cause some erectile dysfunction problems as well, because of that cell death and the smooth muscle tissue.
So isn't there some other, thank you for that. Isn't there some other class of drugs? You talked about the SSRIs for depression, and we know about some of the anxiolytics for anxiety that can, maybe precipitate sexual dysfunction. But aren't there some other drugs, maybe like blood pressure drugs and stuff like that, that we should really watch for that can cause that? And as a urologist, do you talk to your patients about that?
Yeah, I mean, that's certainly, I mean, a lot of people are on blood pressure medications, certainly from high salt, high sugar intake and not enough water intake, and the dysregulation that happens in the vascular system because of that, and also just lack of activity, right? That certainly plays a role in blood pressure. I mean, there's a ton of different, we could probably spend a whole hour just on all the different medications, but yes, blood pressure medications specifically, it's known that if you decrease for instance, if you have or even if you have high blood pressure, if you decrease your blood pressure about 10 millimeters per mercury, which is, if you're 150 over 80, dropping down to 140 or 70 on those numbers, essentially it's known to precipitate a worsening of erectile function. And so from that standpoint, remember, your system is a big pump. If you're relaxing the vasculature everywhere else, because usually to some extent, not necessarily in a severe nature, but to some extent, as you're essentially kind of becoming aroused, it kind of clamps down and funnels some of the blood to the penis, right? And so if you're essentially relaxed throughout your entire system, it makes it that much harder to essentially kind of build up the pressure that you need to create an erection. And so that's where, certainly blood pressure medications can be a big problem, precipitating ED issues and could be, one of the big drivers of folks walking in the door to essentially get treatment for erectile problems.
And so with all these different treatments, it sounds like, from a pharmacist standpoint, the stepwise approach would be the phosphodiesterase inhibitors like tadalafil, Cialis, Viagra, things like that first. And that doesn't work for everybody for obvious reasons, like you stated, but they are oral medications, so they're going to be the least invasive. And the second step would probably be like possibly an injection. Like you're talking about, alprostadil, possibly, at least I'm going from a pharmacist standpoint. I'm thinking from pharmacist standpoint. So the great news is we have other things rather than pharmacological interventions. And the last one being that you talked about is an implant, an implant.
Right.
And so is there any reason, Dr. Wallen, that somebody couldn't have an implant if they failed all the other treatments? Is there any reason they have to live with erectile dysfunction, or could they be a candidate for an implant, or why not?
Well, I mean, there's certainly some counterindications. I mean, obviously there's allergies to the materials in these devices, very rare. Seen it maybe only in 1 or 2 patients that I've seen. And I don't think the literature would suggest that it's the incidence of that is much higher. By and large, remember, to some extent, if you've had radiation therapy to the pelvis, if you've had surgery to the pelvis, all these different things that could potentially be an option, or if your heart or your lungs are not strong enough to undergo a procedure, then those could be reasons you may not necessarily be a candidate. But otherwise, it's basically done through a small little incision like this. So even for a diabetic person, it could be done through a number of different incisions, but a lot of times it's a small little incision above the penis. Even for a diabetic person, and if you're concerned about wound healing, whether you're on immunotherapy drugs or whether you're diabetic or other things, that small little wound should heal even in that nature. So by and large, most people would be a candidate. Certainly if you have severe COPD and you just can't tolerate it. One of my old mentors used to always say, listen, that guy couldn't even tolerate a haircut, let alone a surgery. So from that standpoint, if you can't tolerate a haircut, then we probably shouldn't be doing a surgery on you. But, unless your heart or lungs are that bad, or, for some reason, remember, to some extent, if you've had previous radiation to the prostate, a lot of times, unfortunately, the penis will be involved in that field, depending on if you've had external beam or seed therapy. We're specifically kind of more mentioning about external beam therapy. And that can kind of cause some scar tissue and certainly can cause some problems or potential more difficulties with doing the surgery, but that doesn't mean that it can't be done. So from that standpoint, pretty much anybody could be a candidate. I think a lot of times, unfortunately, it's a little bit psychological, right? And so I commonly hear from guys, hey, I'm ready to do anything, but I don't want surgery, or I don't want a procedure done, or what have you. But quite honestly, it's not just about an erection, and that's where I think trying to keep it classy, to some extent, it's intimacy, right? And so that's a quality of life component that to a large degree can actually kind of restore relationships if they're present and they're corrected, and essentially kind of bring that vitality and youth back. Again, that's where I love regenerative medicine as well. And obviously, if we could all essentially kind of take an injection or an IV or whatever and fix whatever problem we have and be exactly like we were when we were 20, of course, we're all going to sign up for that. But in some cases, that's just not the possibility. And so that's where I think you have to be open to the options that are out there that could be effective for you. Because quite honestly, again, folks always laugh about it, but these penile implants, they have high satisfaction. I mean, with the millions of guys that have been implanted now, patient satisfaction is 95 plus, partner satisfaction is 90 plus, and they're actually very durable. I mean, they last upwards of 15 years, 60 to 80% of guys are still functional 15 years later. So from that standpoint, I mean, you could potentially have one procedure done. And again, if you ask me about it, and I always tell my patients this because I try to tell people exactly what I would want for myself with the knowledge that I have, or my family with the knowledge that I have. I always tell people I'd much rather get an implant than be poking my penis with a needle every time I want to have sex. Because really, quite honestly, that's not very fun when you think about having intercourse or having activities have to be jabbing yourself with a needle down there. So,
it kind of ruins intimacy, like you're talking about, really.
Right. It's a huge problem. If I mean, I guess there's a certain amount of pain some people like, but that's not a pain that I really want. I always kind of joke around with my guys, and I'm just like, listen, I've never ever would I have ever wished that I would have to poke myself in the penis with a needle, throughout old age. So,
well, and I did just on these penile implants, I did talk to a patient, and she had a partner who had prostatectomy. Right. So he needed an implant. He tried all the other avenues and he needed an implant. Right. And this is what she told me. And I think I told you a story, and she might be making some of this up. I don't know. But they have these and she could control it by Bluetooth. I'm just, that is super cool. And I could see that being, actually kind of a part of foreplay. So, and that's kind of how she used it. So, technology is wonderful these days. And, we need to take advantage of that. So, in our world of direct care, Jared, Dr. Wallen, and transparent pricing, let's talk some prices. And we'll just go from the stepwise approach. I can kind of help you with the pharmacy stuff. So really, for Cialis or Viagra, now that both of them are generic, you should not be paying more than $2 a dose. And with Cialis, which is tadalafil, and we make up tadalafil in our pharmacy, you can actually take a good dose on Friday, and it lasts you all weekend long. So that's the nice thing about it. It not only works faster than Viagra, but it works longer too, which pharmacokinetically doesn't make sense, but that's just the way it works out. And I haven't really looked at the kinetics of why it does that, but it does. So it's definitely, in my opinion, the go-to over sildenafil, which is Viagra. So Cialis generic is probably the go-to. You shouldn't pay more than a couple dollars a dose. If you are, please reach out to my pharmacy. We can help you out. And the alprostadil injections, I haven't done those in a while, Dr. Wallen, so you have to help me. But if you get them to a compounding pharmacy, they should be less than $4 or $5 a dose. Is that correct?
Yeah, I would say that's a pretty accurate price. I mean, usually you get about a 10 milliliter vial, and I think it's roughly $50 or $60. Yeah, maybe a little bit more. So I mean, certainly, I certainly agree with you on the Cialis standpoint. I mean, it's probably the go-to in my practice. Yeah. I think it avoids a lot of the side effects, the blue vision, the stuffiness, the headaches that Viagra can create. And again, like you mentioned, if it lasts in your bloodstreams for 2 days or a little bit longer, then you save money by not having to take more medication and still getting benefits, right? So from that standpoint, I think that's pretty much the go-to in any practice, any potential patient that I talk to.
And vacuum erection device, one of the benefits of the vacuum erection device is there's not a lot of disposables. So once you buy the device, which is like $400 or $500, is that right? About?
Nah, nowadays it's actually like about $100 is probably.
Oh, is it really? Wow.
Average cost, yeah.
And the rings are reusable, so you don't have a lot of cost there. So that's what those are going to be less than $100. Again, those might be kind of inconvenient to use, but if the drugs don't work and you don't want surgery, then that definitely is an option. And then surgery, that's your wheelhouse, Jared. I'll let you take over on that one for the implant.
Yeah, so surgery, I mean, obviously implant prices vary. I would say a good generalized implant price from a cash standpoint would be about 10 grand. Obviously you're looking at, another probably $6,000 for anesthesia and surgery center, because it does need to be performed in a surgery center. It cannot be performed in an office at this point. And then, obviously a couple of grand for a surgeon fee. So I would say a good ballpark for that would be somewhere between $16,000 and $20,000 out the door for erectile restoration surgery.
And then as far as after that, is there any kind of maintenance on these things, or, we
got to check the oil about every 3 months. I'm just kidding. There's not a whole lot of maintenance. I mean, obviously the biggest thing that happens after the surgery, obviously you do need a short recovery period, usually between 3 to 6 weeks, depending on your surgeon's standards. And then other than that, it's really just learning how to use the device and being able to operate it is the biggest thing that folks have to overcome, which, again, that's where I mentioned there's a couple of different types of surgeries. A lot of times you can essentially do what's called a suprapubic or infrapubic surgery, where you do a small little incision above the penis in the skin here, or what's called a penoscrotal surgery, which basically does a small little incision at the top side of the scrotum, underside of the penis. There is a third, which is called subcoronal, which basically is kind of a circumcising incision, but that's not used very much, more in advanced Peyronie's disease. But, from that standpoint, especially this small little incision up here, I mean, the nice part about it is it avoids the scrotum completely, which is a bit dirty to some extent. You get sweaty and whatnot in the creases of your growing. But basically, the big thing is, afterwards, the nice part about not having an incision down here is folks can start kind of pulling down on their pump and just making sure it stays in the middle of their scrotum as soon as 2 or 3 days after the procedure. And then basically within the first 3 weeks, they're actually already inflating and deflating. So to inflate, all they really do is just kind of pump after they felt the ball of the pump. And then to deflate, they just essentially kind of find the little button and basically kind of, essentially kind of squeeze that in the opposite direction, and that causes it to come down. So that's the biggest thing that folks need to kind of overcome in the aftermath of surgery. Otherwise, unless you have, for some reason, the implant kind of sticking out through your skin because you're too rough, or because you've had skin breakdown in that area, or something of that nature, or if sometimes, these little tubes can unfortunately malfunction and break where essentially the fluid leaks out. It's not harmful. It's injectable saline, so it's safe. But, that could be a reason for repair. But again, the rate of that is pretty low, from that standpoint. Again, 60-80% of these are still functional, 10 to 15 years later. So, from that standpoint, it's a minority of folks that are having those issues. Obviously, again, unfortunately, if you have, dental fillings, you do need to be careful and potentially maybe take some different antibiotics as prophylaxis, or other types of systemic infections. That's the one big thing that can happen. We say that the incidence of infection in this situation is about 1 or 2% for an initial surgery. If you have to have a revision surgery, that jumps up to about 15 to 20%. And to some extent, unfortunately, remember, just like a knee or a hip or a shoulder, if that implant becomes infected, then it has to come out. It can't stay in there. It will never clear the infection that way. And so from that standpoint, you essentially either need to have, there are some little rods that can kind of go in there as kind of a space saver, because we don't want those little chambers to collapse after we've kind of already inflated them and essentially kind of disrupted the normal soft tissue in there, smooth muscle soft tissue in there, because they will collapse and scar down. And that becomes a much, much more significant surgery to try to fix. But Again, there are some rods that can be placed in there for a temporary period of time. They can be functional as well, and essentially they can be used that way. But ultimately, a lot of guys will essentially kind of elect to go back to the inflatable device just because the rods are they're I think they're nice if you don't have manual dexterity. And I know you mentioned the Bluetooth activation. I don't think that's actually on the market yet, so I'm not sure what your patient was referring to, but it is coming. There is one of the implant companies, Boston Scientific, that they've been working on that for a while. So hopefully, actually probably within the next year or two, that may be on the market. So that, because that's actually one thing. Remember, in order to get this fluid hydraulic system to work, it's a manual pump, right? So if you're 70, 80, 90 and you're otherwise healthy, but it's not working downstairs and you still want to be able to have that portion of your quality of life, you either have to have a partner that can do this pump, or you got to be able to use both hands, or, again, that's one reason where the rods can be a potential better option. Unfortunately, it's just a little bit funky to kind of bend them up, bend them down, and try to kind of hide them. Whereas with this, again, these cylinders are inflated right now, but I can grab the little pump on the ball valve on the pump here, squeeze this, and you can't hear it necessarily, and I'm just going to squeeze it to speed it up, but basically all the water is transferring back to this little fluid reservoir as we're talking. And basically with that, then you're actually pretty flaccid like you otherwise would be, other than, you do have a little scaffolding, little structure that you may kind of notice differently than it was physiologically, the way God made you. But again, it's a lot more easy to hide that than it is, kind of some semi-rigid rods.
Awesome, Dr. Wallen. Always a pleasure to have you on. You are definitely an expert in this subject, and I appreciate you sharing your knowledge so much. So I always appreciate your time. So as we finish up this podcast, where do people get a hold of you if they want to get a hold of you?
Yeah, so youandwe.com is our website, and our phone number is 941-212-1600. So you can go either way. That'll get directly to me and who our staff, and those are the best ways to get in touch. Obviously, all the social media is always out there too, but those are direct routes.
Thank you, Dr. Wallen. You've definitely realized our goal of educating and empowering individuals to take charge of their health. And erectile dysfunction, sexual health is very, very important for our overall health. So thank you for educating us.
Have a great one, everybody.
All right. Thank you. And thank you, listeners and viewers, for tuning in today. We tune in Monday because we will be back on our regular schedule. Monday, 12:30 to 1:30. We will have Dr. Michael Turner. He's been on our podcast a couple times before. He specializes in functional medicine and hormone balancing also, and he's going to be talking about anti-aging. So I think it's a very important subject because none of us really want to get older. We want to think about how we can stay youthful, even though it's impossible to really stop anti-aging. But how do we make it so we age healthy? So he's going to be talking about that. So tune in Monday, 12:30 to 1:30. Health Solutions with Shawn and Janet Needham. Thank you for tuning in.